Elhaddad.
Well, thank you, Dr. Isa. It's really my pleasure to be with you here today. It's my first MESTRO meeting, and I hope it will not be the last. Can you see my planning system?
Yes, we see.
So I'll try to make it more of a practical thing rather than a lot of theory, because I think that during the last few hours you had everything covered from the evidence-based aspect. I thought, with agreement with you, Dr. Isa, that we think that we'll make it more of a practical session, and we'll make it light and to the point. And as Dr. Bassem just mentioned here, I mean, all guidelines are there, and it's easy to look at it and look and get your planning system and open it and contour and just follow the guidance. But what I want to do here is to share with you some thoughts about how you would do it. I cannot say it's a kind of some criticism about the guidelines, but I want just to highlight a few points in the guidelines that I would like all radiation oncologists, or at least my colleagues working together, or I can share also the experience of you guys to see if there is a common agreement about a few points in the guidelines that should be addressed there. When you look at the guidelines talking about a primary tumor for laryngeal cancer or advanced laryngeal cancer patient, you first define what is an advanced stage disease. And when you look at the data, we're talking about stage 3 disease or stage 4 disease. It's basically T3, T4 diseases, or T1, T3 plus N, like a lymph node positive disease. But in reality, T3N0 disease, I usually say it's a separate disease entity, and I would love to separate them outside the advanced stage disease, because the definition of T3N0 disease is a bit tricky. So if you look at the URTC data, the post-operative adjuvant setting, they excluded T3N0 patients from the concurrent chemoradiation arm, saying that they cannot be treated as a high risk, because T3 disease can start by a small disease encroaching on the paraglottic space, or you can have a bulky disease encroaching on the cavity and causing a lot of problems, and we will still call it T3 disease. And T3 disease as T3N0 is not only in larynx. And when we talked about nasopharynx, I told maybe my colleagues that T3N0 for nasopharynx is also a very unique type of patients that you may think of, for example, radiotherapy without chemorad. The same thing for laryngeal cancer, this T3 disease or early T3 disease. You may think of, would radiotherapy be enough? There was data into 2007 asking the question, should we really treat all lymph nodes for T3N0 disease, or can we define few patients to favorable and unfavorable? So T3 disease, putting them in advanced stage disease as a kind of ipso fact, I think this is something need to be addressed and need to be think about. When you talk about T4 disease, you're talking about tumor going outside the voice box. So going outside the voice box, extending, is it extending through the cartilage through and through? Or is it extending because there is a weak point in the voice box structure that allow the tumor to creep and go outside, like what we call it, the thyrohyoid membrane, for example, or a weak point in the thyroid cartilage called the Broyles ligament, for example, something that you see extending from the anterior commission anteriorly, and you will still call it T4 disease. So call T4 disease, T3 disease, using chemorad, using surgery upfront, using neoadjuvant chemotherapy. I think it's a lot to take, and you need a lot of like a comprehensive approach about a speech language team, radiologists, surgeons, to take a decision for those locally advanced stage cancer larynx. And this is the beauty of cancer larynx. It's not just a unique disease that you put this stage and treat as is, or you put like a clear guidelines or clear cutoff. This will go to induction, this will go to radical chemorad, this will go to to like a concurrent chemorad, or this will go to radiotherapy alone. You have like a very kind of a complex types of disease that will be all under the locally advanced T3, T4 disease or N+ disease. So it's not just a unique kind of single disease that you put it under single title. And this is one of the beauty of this tumors, I have to say. The guidelines would tell you that when you treat a patient, you have to collect all data available. So you have a CT, you have a PET scan, you have an MRI, you have, and more importantly, I think what we forget is how the tumor looks under the scope with the cameras. When they put the cameras inside and put the patient to sleep, one of the most important detailed information that you should be aware of is what kind of how the tumor looks, and is there is extension, and where is the extension? Because sometimes when you look at your planning system, like the one I'm presenting now, the tumor may be very obvious, like this one is very clear that this is a tumor there, and you can define it easily. But in fact, there may be some cells or some changes happening around the vocal cord or the opposite side that you may not be aware of except by getting the scope data. So all data should be available before you go for your contouring. And then when you look at the contouring for glottic region, supraglottic region, or subglottic region, based on the Gregoire data, he'll tell you, you just go for the GTV, and it's easy to define. It's not a big issue. I will not go for a lot of details about that, but I'll just put something as an example here. If this is like, for example, my GTV, and we be a bit accurate, it will tell you that you just add 0.5 centimeter margin, the 5+5 rule, or 5+5, another 5+5 to add what we call it CTV2. But don't forget, please, with locally advanced stage disease, there is a bit of a hint that usually it's missed. In the guidelines, they will tell you that if you are a center who is using a 3-dose level, you may have to delineate CTV1, CTV2, and CTV3, and it's completely acceptable. And for myself and for our center, we consider patients with locally advanced disease we may need these types of CTV1, CTV2, CTV3, and I will tell you why. If you follow the guidance clearly, it will tell you that you add a 5 mm margin around this. Let's say I'll just try to do it quickly. So CTV1, if you use a 5 mm margin around this one, and it is like auto margin you're doing, usually you don't take a lot of, don't a lot of changes for a locally advanced. I'm talking T3, T4 disease, by the way, because I'm sure that Dr. Isa covered the early stage disease. So it's a concentric kind of like auto margin, we do it. And then we'll tell you that another 5 mm for CTV2 to cover what we call it a microscopic extension or a lower dose disease. So you end up by having CTV1, CTV2, something like, just for a demo here, so just a quick thing. But when you look at this, and this is something we need to think about it together. So look at it carefully here. To tell you that if it's T3 disease, you don't have to cover the strap muscles. So you end up by removing the strap muscles. If you have a T4 disease, which didn't specify where is your T4 disease, and the tumor is extending outside the thyroid cartilage, then you take the strap muscle into consideration. The trick point here is, if you take an auto margin of 5 mm only, you may end up by missing the strap muscle. If you have a very thick strap muscle, you may end up by missing the strap muscle. And in the craniocoronal direction, you may miss part of the strap muscle. The guidelines wouldn't tell you that. How far or how like how much coverage would you take the strap muscle. But I'm sure that if you get your CTV2 very close to the strap muscle, not taking it, and you have any doubt that the strap muscle are affected, I would say that you may extend it outside and you are not obeying the 5+5 rule. And this is a very important point. Don't stick to 5+5 rule if you think that there is an area where the tumor may spread to, or maybe at high risk of spread of microscopic disease. So the 5+5 rule is fine, but it's sometimes when you go for your practice, you may feel like, oh, I'm doing the right thing. I'm just taking very small part of the muscle while there is a risk muscle infiltrated, especially if you have a sick strap muscles, the the sternohyoid, or part of the thyroid muscle as well. It depends on which level are we talking about. So this is one. A second point, which I think it's very important, is when a tumor extends to the paraglottic space, and we all know that tumor extending to the paraglottic space is a T3 disease. But when you take the margin of 1 centimeter, I can reassure you that extension to the paraglottic will be covered properly. But you may miss is what we call it extension to the the periglottic or the pre-epiglottic space. And the trick here I want you to take care of, that the paraglottic space is in continuity with the pre-epiglottic space. So if you look at the sagittal view here, I hope you still, my sharing is very, very clear. So if you look at the sagittal view here, and I will go to the tumor now. So if you look at the tumor, look at the space that will appear, which is the pre-epiglottic space. The tumor, I'm sorry, I'll just put a cursor here. Just remove the brush. So if you put your cursor in an area where the tumor is situating, and when you look at the sagittal view now, look which space is appearing here. This is a pre-epiglottic space, and the pre-epiglottic, para-epiglottic space, actually they are one space. So for me, if I take 5+5 and I end up by, let's say, let's get the cut, we drew it now. So, and we end up by something like that. It's clear from this cut that you are covering the pre-epiglottic space, but you are covering the pre-epiglottic space in the lower part of it. So what about the rest of it? So should we add a CTV3? And here is the importance of you and your team agree about whether you will take CTV1, CTV2 only, or you'll take CTV1, CTV, and the rest of the larynx will end up by the low-dose radiotherapy, because of the locally advanced disease is a bit different from an early stage disease. A third point I want to highlight is the extension to the subglottic region. We don't have a pure subglottic disease, or it's very rare, let's say it like that. But the point, if you have a disease extending to the subglottic space, which is the space below the cord, we define it as 5 mm below the cord. When you go to the subglottic space and you look at the guidelines, it will tell you still obey the rule of 5+5. I mean, come on, guys, who knows that? I mean, who knows that 5+5 will be enough for an extension to the subglottic space? GTV is fine because you see it. But how much of microscopic submucosal extension will happen or is happening there? I think there is a trick there. And that's why I would just, with a caution, I would say, if you are from those who are using the CTV1, CTV2 only, please be generous on CTV2. So be generous in the subglottic space. Be generous in a patient with extension to the paraglottic space with a potential extension to the pre-epiglottic space. They are one space. They cannot be separated. I'm not saying the guidelines is wrong, but the guidelines was very clear. This is a guidance. It's not is not something to tell you how you treat your patients. What I'm telling you here is things to think about when you face it. So when you think a tumor there, so what about the pre-epiglottic space? How much risk is going there? When you go to the subglottic region, how much risk would be the subglottic going down to the subglottic space? And one other important thing, I think, for this cartilage, when the staging is talking about T4 disease, it's talking about the thyroid cartilage as T3 inner cartilage invasion, like erosion, and then if it extends beyond, it will be T4. That's fine. So what happens if there is a minor erosion of the cricoid cartilage? Is it a T3 or is it a T4? We don't know. And I asked this question to Dr. He's the one, so from Princess Margaret, maybe Dr. Ali as well can help us on that. And I asked this question to, sorry?
Brian O'Sullivan?
Brian O'Sullivan, and he said, yeah, I mean, we don't know. I mean, there is no data about it. And Brian, and because he's one of the team putting the staging. And so if minor cartilage invasion, will you consider it as similar outcome as a patient with extensive thyroid extension? If it's a minor cartilage invasion, you still call it T4 disease. What about a patient with sclerosis in the arytenoid, something like my patient here? Sclerosis of the arytenoids can be a true invasion, which is some radiologists would call it, there is a high suspicion of invasion. Let's do an MRI, get a T2 with fat suppression. Let's do this, let's do that to get more information about it. But if you don't have an MRI, what would you call this patient? Is it a T4 disease? What kind of prognosis would you tell your patient, and how aggressive you would treat him? So T4 disease for such patients, you should be very careful as well. And whenever you see sclerosis, even if it's away or if it's close, how would you treat it and how much dose would you take it? Would you take it from the GTV and push more dose and end up by risk of arytenoid problems? Or you put it as a CTV, or will you put it as a low dose if it's away from, or you just neglect it if you have an evidence, an MRI? So these are like a lot of questions regarding this, how you would delineate your laryngeal cancer patient. The guidelines will tell you, for example, remove the air cavities. That's fine, we'll remove the air cavities. So what about the vallecula? So area like this, what I call it the face of the Donald Duck, eyes, cap, and mouth. This is the vallecula is a potential space. Should I remove the air here? I don't think we will do that. And what about the vallecula as a whole? Would you take the vallecula as a separate like space, or you just, if the margin extend into the vallecula, you just take it and that's it? And what about the rest of the vallecula? Will be at risk? There is no barrier. It's just the epiglotto, the hyoglossus or hyoepiglottic ligament, in the hyglossus ligament in the middle, and it's nothing there. It's not a barrier. It's not a true barrier. How would you deal with that? A true suprahyoid epiglottic tumor setting close to the tongue. We know that the 911, the excluded patients with base of tongue extension more than 1 centimeter. Are you gonna do that? We don't know, actually. I mean, excluding the patient having a poorer prognosis, especially if it is like P16 negative patient, we don't know if it's induction chemotherapy. How far should you go for those patients? Do you still treat the same? So T4 disease, I would call it, is a very, very interesting disease entity, and even T3 as well. So they are not separate single disease, and I would strongly recommend that we treat them as a team to sit together and see the patients, speech therapy team around us, the dietitian around us, the surgeon with us, and radiation oncologist sitting there. We treat the patient as a team and get the best outcome for our patient, and they usually really do very well. I really like to treat laryngeal cancer patients X hypopharynx. So if it's not hypopharynx, I'm happy to give them a good hope, and that I get usually very good results for that. I asked Dr. Isa that I make a bit of practical things about how would you treat, how would you draw the brachial plexus to make it simple for you, and how would you treat the pharyngeal muscles, because it's a very important part here, being a locally advanced disease. You will be facing patients that your pharyngeal muscle will be affected. What would you do for it? And we know the data of the DARS trial now is coming, or it's published already. I'm not sure how to apply it in the daily day-to-day practice, honestly, but I'm really interested to draw all pharyngeal muscles for my patients, because if I'm collecting data for future, this will help a lot. So I'll start by giving you a very simple method of drawing your pharyngeal muscle, and I hope you'll find it useful and easy to do it in your daily practice. The pharyngeal muscle, now we have one of the softwares we have is called the mVision. We are using it for auto contouring with auto segmentation. So with just one click, you just put everything, including brachial plexus, including pharyngeal muscles. But honestly, sometimes you need to be aware of what's going on so that you can put your your touches there. So the pharyngeal muscles in the last guidelines, there is a lot of guidelines talking about the pharyngeal muscles, and some of them, they separate them into superior constrictor, middle constrictor, and inferior constrictor. But the last head and neck guidance would say just draw it as all at once, which makes sense, more sense, honestly, because we know that there is an overlap between the superior constrictor and middle constrictor and inferior constrictor. So it's a bit of overlap between both. It's very difficult to delineate where it begins and where it ends, although we know that superior constrictor may start at the sphenoid hamulus and end at the second cervical vertebrae. This middle may start on the upper body of the hyoid and end at the lower body of the hyoid, and then the inferior constrictor start at the thyroid cartilage and end at the cricopharyngeus muscle. But still, you cannot put a cut off, and if you started to do that, it will be a lot of confusion. So I really liked the last guidelines say just do it as once, and to do it in a very simple and easy way. All what I do is I draw it in a very few cuts, and I try to interpolate, and it's done. And I look at it carefully before I interpolate, and then it's easy. So if we try to do it as a simple thing, is you just use a very thin brush. The guidance would say 2 mm, but I will make it thicker than that. And then start by looking at the pterygoid plate. We all know that the pterygoid plate is posterior, for my junior colleague, posterior to the maxillary sinus, is sitting there. And then the last point, the lowest part of the pterygoid plate is called the hamulus. This is the point here. You can see it here. This is a pterygoid plate up, go down till you see this dot there, which is the pterygoid hamulus. And as not I don't forget the upper border, or where to start, I call it sphenoid hamulus, second cervical vertebrae, superior constrictor. So superior constrictor start at the sphenoid hamulus and end at the second cervical vertebrae. And when you go to the sphenoid hamulus, you see the pharyngeal muscle in a very easy way. It's a U shape going from one side to one side. So if you end up by drawing something like a U-shaped structure like that from the hamulus to the hamulus, and you take the wall, which is usually very thin, I don't think it will be more than like few millimeter. Posteriorly, you don't have to take the prevertebral muscle and try to be as thin as possible. You will notice that there is no muscle in the middle here. So if you in reality, this middle part is nothing but what we call it a raphe, where the pharyngeal muscle, if you remember the old photos of pharyngeal muscle, when they join together in the midline, they join in the raphe in the middle line that starts on the occiput up.
and go down to the neck. So that's why it's very thin. So there is no way you exclude the mucosal lining in here. So you'll take it as such, side by side, U-shaped structure, hamulus to hamulus, and posterior wall of the pharynx is part of the pharyngeal wall. And then go down and keep an eye on this structure, which is the mandible. This is the ramus of the mandible. Keep an eye on this structure and keep an eye on the end of the mandible. What will happen is this U-shape will try to be V-shaped to join the ramus of the mandible. Look what is going on when we go down. So I just push my cursor down. Look what is going on in the muscle. This is the muscle here. Look at how it opens, and it as if it is going to join the ramus. So that's why at this cut, I usually draw something like a V-shaped structure that represent the part of the inferior, the middle constrictor. And if you look at the guidelines, you will see the two ways of drawing it. One way is joining it to the ramus of the mandible, but this is wrong in reality. Actually, what's happening in anatomy, that there is no junction between the muscle and the ramus of the mandible. But why would the guidelines draw it like that? Simply because there is a raphe called the pterygomandibular raphe. There is a raphe ligament that will connect the pharyngeal muscle and hang it to the ramus of the mandible. And that's why some of the guiders will draw it like that. But I would prefer to make it V-shape and avoid drawing it, extending it to the mandible, and I end up by, as I can see it, you can see it, it's a kind of a V-shaped structure on the side of the pharynx, and as thin as we can. Again, the posterior wall is very thin because it's just mucosal lining and raphe in the middle, and that's it. And then go down, keep an eye on this, and go down to where the tongue is located. So when you go down, you'll see the base of the tongue coming out, is it? This is the base of the tongue. We all know that. The muscle, the pharyngeal muscle, is nothing but junctioning the edges of the tongue. So from this side of the tongue to this side of the tongue is your muscle. And you'll end up by what I call it a plate-like structure. So it will be, I'm sorry for this, but it helps a lot my trainees and my colleagues to remember it. So it will be like a plate-like structure like that. And you'll go with this till you end up to the bone, what you call it, the hyoid bone. But when you go to the hyoid bone down, so I'm going up, go to the hyoid bone, and you just stop at the lower part of the hyoid bone. So you just draw it and stop in there, because there is a new start that will appear whenever the thyroid cartilage starts to appear. After the hyoid bone, we know that the thyroid will come. And whenever the thyroid comes, this will be the inferior constrictor. The inferior constrictor in reality is divided into two portions. The upper portion is related to the thyroid cartilage. It is nothing but it is the muscle in between the cartilage. But if you go down to the cricoid part of it, you will have what we call it the cricopharyngeus muscle, and this is a very thick muscle that you will never mistake in posterior to the cricoid cartilage itself. So you can see how thick is it, and it is off the cricoid. So this is the cricopharyngeus muscles. The part of the around the thyroid cartilage will be the thyropharyngeus muscle, or for simplicity, just called inferior constrictor. But I am aware that a lot of centers now take the constrictor, the cricopharyngeus, as a separate, being strong, being more tolerable, and may be a part of research, but how much dose can go there, how much dose should be up there in the thin part of the muscle. But anyway, this is a pharyngeal constrictor, and you can see it easily here. It's a posterior to the cricoid cartilage, and that's it, and that's it. All what I do now is I look at my interpolation, if you can see it, and then you may end up by something like a defect if I see it. So I just try to complete it, and then I just interpolate, and you end up by doing the pharyngeal constrictor. So something like